right? So we're recording, and we'll go into the presentation for diagnosis. So what we'll talk about, the main thing I want you all to get from this is when we talk about diagnosis, we look at this thing called the 2x2 table, which is a table that is done in diagnostic studies, and you will be able to do the basic calculations that originate from this table. So what do diagnostic studies tell us? Diagnostic studies, again, answer a particular question. Diagnostic studies answer the question that, we could phrase in PICO, the first step in practicing EBM. So again, this is an example. We saw an example yesterday of what PICO looks like for treatment. This is what PICO looks like for a diagnostic study. So in a 24-year-old prima gravida, that's a lady who's having a baby for the first time. I know you all haven't done your O&G rotation as yet. How accurately does fundal height compared to fetal ultrasound predict the outcome of fetal age? So again, I know you all haven't done O&G, and essentially what fundal height is when you do your rotation, you just take a measuring tape, you measure from the pubic symphysis, the bone lower down there, the most inferior part right there in the pelvis, and you measure from that point to the top of the womb or the uterus by palpation. And when you do that measurement, we know that that measurement corresponds roughly to the gestational age. So if you do that measurement and you get 26 weeks, 26 centimeters, that's equivalent roughly to about 26 weeks, give or take 2 weeks for gestational age. But how we knew that? We knew that because at some point in time, someone did a diagnostic study or a DTA study. The other way to describe it is a diagnostic test of accuracy study. So DTA studies or diagnostic studies, whatever you prefer to call them, at some point in time, someone did a diagnostic study and they took everyone who was having a baby and then they measured the symphysis or fundal height, and then everyone got an ultrasound, and then they actually tried to see how well does this measuring height compare against ultrasound, which is the gold standard to tell us gestational age. So all diagnostic studies try to answer a question like this. In patients who might have a particular condition, how well does some test, the intervention, compare to some gold standard in predicting the outcome? Right? So this is what DTA studies tell us. And I have another example here on this slide. Can D-dimers diagnose DVT in someone presenting with calf pain and swelling compared to a Doppler ultrasound? So here you could kind of get the PICO from the second point. The P, the patient, would be patients coming in with calf swelling and calf pain. Not everyone coming in with calf swelling and calf pain have a DVT, as you all may know or soon realize, but it's one of the big differentials, especially if a person has a unilateral calf pain and swelling. So in a patient who presents with calf pain and swelling, that's a P, can D-dimers, that's the I, compared to Doppler ultrasound, that's the comparison, in this case the gold standard, give us a diagnosis of DVT. And in this case, the gold standard Doppler ultrasound, that would be fairly accurate in telling us the diagnosis all the time. So when you do a diagnostic study, you actually need to compare patients to the gold standard, which would tell us, if the person have the condition for sure. You can't compare it to some test that wouldn't be diagnostic, because then you wouldn't know how your test is measuring up against that other test. So they have done diagnostic studies like this, and that's how we know that we could use the dimers to a certain extent in helping to diagnose DVT. But we'll see exactly how we use it to diagnose DVTs. Because when we talk about diagnosis, it's really two things we're really trying to do. We're not only trying to say that a person or a patient have a condition, we actually sometimes interested in ruling out or saying that a patient does not have a condition. So when we use a test, we use it both to rule in or to rule out. And we'll see how over the next couple of slides, the measures that we calculate, how that helps us to do that. But before we move on, my question is, why not just do the gold standard all the time? Why not just do In this case, everybody coming in with calf pain and swelling, why not just do a Doppler ultrasound and everybody who coming in with calf pain and swelling? So what you all would think, what you all would say? All right, cost, expense, yeah. A Doppler ultrasound could be kind of expensive, yeah. A Doppler ultrasound is about $700, $700 to $800. Kind of pricey, kind of expensive. It's not a classic ultrasound, so definitely it's not something that I have and I could do as a GP in my office, or even if the patient can't afford to do it. So lots of people posting things like cost and time, limited resources, limited equipment. So you all are all correct. So we can't do the gold standard all the time. So it would be easy and it would be very convenient if we could do another test, but another test that would also give us the same kind of information as the original. And the only way we can know that is if we have diagnostic test accuracy information on that test. I would also say that sometimes we cannot do the gold standard test, because sometimes the gold standard test is something you all did in year 3 that you all now came out of. Sometimes the gold standard test is autopsy or postmortem. So we can't kill the patient just to know what's wrong with them. But certain diseases, and of course, fortunately, this is the exception, certain diseases, sometimes they could only get the diagnosis for sure on postmortem when they do histologic testing of tissues. And those are mainly limited to the neurodegenerative conditions, Alzheimer's disease, rabies, those uncommon conditions, which fortunately we rarely see, especially for things like rabies. We can only know the diagnosis for sure, when you do a postmortem. So when you do a diagnostic study, when you do the research to validate a particular test, this is what you're going to come up with. This is what you're going to be able to draw, because you take a group of people and you subject everyone to the test. On the left-hand side, I have test. Some people call the test the index test, if you want to specify and not mix it up with the other one, the gold standard. So some people call it the index test. So everyone, you take, let me just say 100 people, subject everyone to the index test, and then subject everybody to the gold standard, whatever that gold standard is, depending on what you're trying to diagnose. So each person would really get 2 tests done. That's really what this table is showing. Each person would really get 2 tests done, and based on the results, you'll be able to classify people into one of these 4 categories: A, B, C, and D. So there are 9 cells on this table, as you could see: A, B, A plus D, C, D, C plus D, and the rest below. There are 9 cells on this table. So when you do a diagnostic study, my first question is, which one of these 9 cells refer to everybody who have the disease? Which one of these 9 cells refer to all the diseased, truly diseased people? You could probably post the answer for this one in the chat. Let me see if you could figure it out. I would say it's a trick question, but I know some guy is able to figure it out. Which one of these cells refer to all the people who have the disease? If you were to do a diagnostic study and draw a table like this, what do you all think? All right, so Shivani says A and C. Shari and Satvika says A. So you all have zeroed in on the correct part of the table. Ray is saying A plus B. So we'll come back to what A plus B is. It's not A plus B. But a lot of people think it's A. So it's not A only, it's A plus C, right? So Shivani got this one correct. It's A plus C. Why it's A plus C and not just A? If you notice, the gold standard at top is either you have the condition here or you don't have the condition here. So the gold standard, if it says you're positive, then all these people here are positive. So A plus C refers to all the people who have the disease, not just A. Even people who are C has the disease. The test is classifying C as not having the disease, therefore we call C a false negative. C is a false negative, but it's a false negative, meaning the test is classifying C as being disease-free, but C is disease. So the correct answer for all the diseased people is A plus C. And coming back to something that which one you all posted in the chat. If you thought A plus B, then through that same reasoning, A plus B refers to all the people who had a positive test, not necessarily all the people who have the disease. So don't mix up A plus B and A plus C. If let me just say we were looking at that example where we're looking at D-dimers. D-dimers is the test. The gold standard is the Doppler ultrasound. And you did a diagnostic test accuracy study on a group of people with calf swelling and pain. A plus B would refer to all the people who had a positive D-dimers test. Whereas A plus C would refer to all the people who had a positive Doppler ultrasound, which by the gold standard means really the person have the disease. Right? So you all understand that? You all get that? Try not to mix it up. Sometimes people kind of mix it up. Once you understand this table, that's the key thing to figuring out all the calculations we're going to look at. So Jade is asking then, what is B plus D? So what you think it doesn't? Who doesn't have the disease? And you're most correct, Jade. That was the next point we were going to see. So then B plus D refers to all the people who are disease-free. Right? So you're most correct. A plus C is all the people who have a positive Doppler ultrasound. B plus D is all the people who have a negative Doppler ultrasound. So B plus D are all the people who are negative for a DVT. They are disease-free for that condition. So then you might ask, well, what is B and what is D? So B would be a false positive. Most correct, Catherine. Because B really is disease-free, but the test is saying that the person is positive. So going back to the example I just said, B has a negative Doppler ultrasound, but they have a positive D-dimer. So B would be a false positive. So you all have already figured out two of the big things from this table. You all have already figured out C is a false negative. You have just concluded B is a false positive. So what is A and D? A really has the disease and the test is saying that they're positive. Therefore, A is the, and you take us to this one, true positive, most correct, Justin. And through the same rationale, D is what? D is the true negative, most correct, Celeste. So, perfect. Once you all could figure that out and understand that from this table, the rest of it becomes easy. The calculations, once you know how to calculate the measures, they all make sense. So the key thing I want you all to get is to be able to understand this diagnostic study table. So with the measures that we actually calculate from this table, there are 6 things we can measure from this table. And you all have to be familiar with all of them, but I want you all to be able to calculate and interpret them. That's the most important thing I want you all to get. The first one is this thing called sensitivity. So sensitivity is calculated as A over A plus C. Right? So if you take A and divide it by the total, A plus C, you get this value called sensitivity. So going back to the table, A out of A plus C, out of all the people who have the disease, how many are truly positive? So the other word for sensitivity, because you all just told me A is the true positive, the other word for sensitivity is the true positive rate. Right? So sensitivity is also the true positive rate. Now, how we use sensitivity? I just told you it's a true positive rate. So you might think, well, sensitivity could then at ruling in the disease, telling us if people have the condition. But actually, it's not so. Sensitivity tells us if a test is good at ruling out a condition. Now, that might seem kind of counterintuitive to just what we just explained and what we calculated, but we'll go back to the table and we'll understand why sensitivity is good in helping us to rule out a condition. Usually when you do a test, remember in practice now, when you do a test and all these measures, sensitivity and all the measures we'll talk about, remember it's calculated for the index test. In practice, when you work in and you see a patient coming in with swelling, you don't have the gold standard, so you would order the D-dimers. So let me just say a test is 100% sensitive. Remember, sensitivity is A over A plus C. So if a test is 100% sensitive, what does that say about A and C? Let me see if you all could figure this one out. Most people able to. If a test is 100% sensitive, 100% is 1, and we say sensitivity is A over A plus C, then what does that say about A and C if a test is 100% sensitive? If A over A plus C equals 1, then what does that mean? It means C does not exist. Most correct. C is 0. So a test that's 100% sensitive has no false negatives. Right? Make sense? So a test that's 100% sensitive has no false negatives. So what that means? That means if you do the dimers, let me just say, and let me just say for argument's sake, the dimers was 100% sensitive, and you got a negative test, C plus D refers to all the people who have a negative test. It really means if C is 0, all the negative tests refer to D, the true negatives. And therefore, we could say that if a test is very, very sensitive and they get a negative test result, you're kind of thinking, all right, we have excluded this condition. That's why the mnemonic I have up here for you all to just learn by rote is SNOUT. SN, sensitive, out, rule out. A highly sensitive test is good at ruling out a condition. Of course, when the test comes back negative. So, of course, the test has to come back negative for you to rule out the condition, and that's the way we use sensitivity, right? So I have it up on the slide here, the mnemonic, just to learn it off by rote. If you were confused by what I was saying for the last minute or so, that was like giving the explanation leading up to why it is we have this. But essentially, highly sensitive tests are good at ruling out the condition. Now, people usually ask, what's considered a good or high enough sensitivity? Is it 60%, 80%, 75%, 90%? It's not set in stone. Generally, we say our sensitivity is high enough if it's at least 80%. And actually, all the other measures I'll talk about, sensitivity, specificity, predictive values, we generally describe them as being high if they are more than 80%. But I don't want a number to stick in your head, because sometimes if we want a really, really sensitive test, we may not settle for a sensitivity at 80%. Sometimes we would say, well, I want a test to be really, really sensitive. I want a test to be 99% sensitive. As is the case with HIV testing is 99.9% sensitive. Meaning if you do a HIV test and it comes back negative, you're confident that the person does not have the HIV antibodies in their body. That's what it means. Of course, there could be that window period where the person got infected recently, made antibodies. We'll talk about that next week. But essentially, HIV testing is 99.9% sensitive. And you want HIV testing to be 99.9% sensitive, because you want when you tell a person they're negative, they're really negative. Right? So that's sensitivity. Specificity is the other measure. Specificity is calculated as D over B plus D. So specificity is D over B plus D. So what does this mean? Out of all the people who do not have the disease, D over B plus D, how many are truly negative? So the other word for specificity is the true negative rate, right? So the true negative rate. So D over B plus D, that's specificity. So again, you would say, well, I just told you specificity is the true negative rate, so specificity would be used to rule out the disease. But remember, sensitivity and specificity is calculated in relation to the gold standard result from a diagnostic study. When we use these measures, we're not doing the gold standard test in our practice, we're doing the test of interest. So the mnemonic here for specificity is SPIN. A highly specific test is good at ruling in the condition when the test is positive. SPIN, SP, specificity, in, rule in. And we could go back to the table and understand why again. If a test is 100% specific, and we just said specificity is D over B plus D, then that means if D over B plus D is 100%, then it means B is 0. It means that test has no false positives. So if B is 0 in a highly specific test, and in practice you do your test and A plus B you get positive results, then positive results on your test refers then to all the true positives. This is why a highly specific test is good in ruling in a condition. Right? Make sense? Lost anyone so far? You all following? All right, so I take it the no post in the chat means you all following and not too confused. So good so far. So in terms of sensitivity and specificity, let me give you an example now, and let's use the same D-dimers example. D-dimers has a sensitivity of 90% and a specificity of 50% for the diagnosis of DVT and PE, right? That is probably close to the reality in terms of actually the value of the test. So if I tell you D-dimers has a sensitivity of 90% and a specificity of 50% for diagnosing PE and DVT, what does that say about D-dimers? How are we going to use D-dimers? Remember the mnemonic? Spin and snout. So if we say it's 90% sensitive, it has a good sensitivity. If it's 50% specific, it has a poor specificity. So most correct, Julia and Celeste. It is really to rule out. So that means if someone come with calf pain and swelling and you do a D-dimers test on them and is negative, you're kind of thinking, all right, well, this person probably does not have a clot. There is something other than a clot causing the calf pain and swelling. How about if you do the D-dimers and it comes back positive for a patient? What that means? If it's 50% specific, it means you really don't know. It means some people could have the disease and some people could not have the disease, right? Someone is saying need to do a more sensitive test to confirm, but we did a sensitive test. So then if we say the specificity is poor, then we would need to do a more specific test to confirm, right? So exactly, we need to do a more specific test. That's right. So, and that's actually what we do in real practice. Sometimes if we apply a test and it has good sensitivity but poor specificity, when the test comes out positive, we say, well, we still have to subject you to more testing. But if the test was sensitive and it rules out the disease, and we're kind of confident the person does not have the disease, we could tell the person, well, here what? You don't have this condition, we don't have to treat you for it. You could monitor that person and see if they still develop symptoms of the disease, but that is actually what we do in practice. So suppose I told you, let's give another example, and these are real figures from actual real clinical practice. Suppose I told you intraocular pressure, so that's where they measure the pressure in the eye, has a specificity of 90% for the diagnosis of glaucoma, but a sensitivity of 43% for the diagnosis of glaucoma. What does that mean then about intraocular pressure when you measure intraocular pressure and making a diagnosis of glaucoma? It's 90% specific and 43% sensitive. And actually, those are the actual values for intraocular pressure in the diagnosis of glaucoma. What do you all think about this one? Is it very specific, very sensitive, both, none? What do you see? It's very specific, so it's good at ruling in the condition, most correct. So if you do a intraocular pressure test, and if you all have ever had this done, if you had an eye exam, they could do it with a pen or by pressing something against the eye. They put some numbing drops in the eye and put these pens right on the surface of the cornea. And generally we say it's positive if it's more than 21, if it's more than 21 millimeters of mercury. So if a person has an intraocular pressure of 26, you're kind of thinking, all right, it's positive, the test is positive. So the person probably most likely has glaucoma. But if you check a person's pressure in the eye and you got a value of 14, it's negative. The intraocular pressure is negative. You would say it's a negative test because it's less than 21, the value we accept as the value for pathology. But if a person has a normal intraocular pressure or they have a negative intraocular pressure test, then that person correctly may need more testing. That person actually could probably still have glaucoma, because as you all will learn in ophthalmology later on, that it's possible to have normal pressure glaucoma. You can have normal pressures and still have glaucoma. Definitely not so common, but a lot of people could have it. So that's two examples of how we could use sensitivity and specificity, right? Now, the ideal test is both very sensitive and both very specific. So if we had a test that was 99% sensitive and 99% specific, a good example is like a HIV test, a HIV antibody test, then we would say that's ideal. We would wish and hope that all tests could be equally sensitive and specific and have a high sensitivity specificity. But in reality, when we do diagnostic studies, often one is a trade-off for the other. One is a trade-off for the other, and usually if the specificity goes up, it's at the expense of sensitivity and vice versa. Not always the case, but often the case. So in terms of sensitivity and specificity, those are the calculations on how we would work it out and interpret it. What are the other measures we look at? The other measures we look at is called the predictive values, and there's a negative predictive value and there's a positive predictive value. So what are the predictive values? The predictive values now go across the table from left to right rather than down. Out of all the people who have a positive test, which is A plus B, remember A plus B is all the people who have a positive test, not all the people who have the disease. Out of all the positive test results, how many are truly positive? So if I have 100 positive test results and 85 of them are truly positive, I say the positive predictive value is 85%. Right? So the higher the positive predictive value, the better that test is in that ruling in the condition. Similarly, the negative predictive value is D over C plus D. Out of all the people who have a negative test, how many are truly negative? So if, let me just say, C plus D was 100 people have a negative test, and 40 of them had a true negative result, then we'll say the negative predictive value was 40%. Doesn't sound very good. A test with a negative predictive value of 40% probably is not really good at ruling out the condition. You'd want the negative predictive value to be high. If, let me just say, 95 out of the negative test results were truly disease-free, then you would say the negative predictive value is 95%, and that test will be good at ruling out the condition. So a high PPV is good at ruling in the condition, a high NPV is good at ruling out the condition. What's the other two measures we could get from this diagnostic study table? We could work out something called a positive likelihood ratio, and we could work out something called a negative likelihood ratio. So what's these ratios about? As we see, it's a ratio. A ratio is what? A ratio is something divided by something else. Yesterday we saw ratios. We saw relative risk as a ratio. We spoke about odds ratios, hazards ratios. This is a ratio as well, and it's a ratio of two things. It's a ratio of what? Positive likelihood ratio is a ratio of the true positive rate to the false positive rate. Now, actually, if you look at it, the true positive rate we just said was sensitivity, and the false positive rate is really B. If you go back to the table, the false positive rate is B, right? And we say in the false positive rate, if the true positive rate is A over A plus C, which we know is sensitivity, the false positive rate is B over B plus D. But what's B over B plus D? We just now said D over B plus D is specificity. Therefore, B over B plus D is 1 minus specificity. So in your calculating it, just please put this in brackets. I'm always supposed to enter the bracket sign here. Suppose I could do it here just for clarity, right? Because that's how it's calculated. So sensitivity divided by 100% minus specificity. Let's pick an example. If the sensitivity is 90% and the specificity is also 90%, then sensitivity is 90%, 90 over 100 minus 90. 100 minus 90 is 10. So 90 divided by 10 is 9. If you had a test with a sensitivity and specificity of 90% each, the positive likelihood ratio is 9. So what does that mean, a positive likelihood ratio of 9? Well, we said the bigger that ratio is, the better. How big is big? We want it to be more than 10. So if it's more than 10, we then say that a test has a good probability of ruling in the disease when the test comes back positive. So if we got a positive likelihood ratio of 15 or 20 or 100, we would say, well, hey, that test is really good at ruling in the condition. If we got a positive likelihood ratio of 1 or 3 or 0.1, we would say that test isn't really so good at ruling in the condition because the positive likelihood ratio isn't more than 10. Now we might wonder why they pick 10. It's an arbitrary pick. Some people might say more than 5 is moderate, more than 10 is really good, more than 20 is excellent. So it's definitely not set in stone. But the idea is the bigger the ratio, the better. If we got a positive likelihood ratio of 20, what we're really saying? We're really saying if we do a test on a patient and the test comes out positive for a particular patient, and that test has a positive likelihood ratio of 20, what we're saying is we're 20 times more certain that that test represents a true positive than a false positive. So the bigger the number, the better. If a positive likelihood ratio is 100, it's great. If a positive likelihood ratio is 1,000, it's probably perfect. But that's the idea. That's a positive likelihood ratio. So if the positive likelihood ratio is more than 10, good at ruling any condition. That's the take-home message. And similarly, negative likelihood ratio is the false negative rate divided by the true negative rate. We just now said the true negative rate is specificity. Was the false negative rate? You all know from the table, you all told me at the beginning, the false negative rate was C. The false negative, sorry, was C. So the false negative rate is C divided by A plus C. But what's C divided by A plus C? We didn't work out just now. We worked out sensitivity, which is A over A plus C. So the false negative rate is 1 minus sensitivity. That's what the false negative rate here. So again, this should be in brackets. So I'm going to put it in brackets here. And that is what the false negative rate is. Now, this is kind of like the flip of the positive likelihood ratio. This really is, we say it's good if it's less than 0.1. So let's use the example I just gave of a test having a sensitivity and a specificity of 90%. If a test has a sensitivity and specificity of 90%, with the negative likelihood ratio, 100 minus 90 is 10. And specificity is 90%. 10 divided by 90 is what? 10 divided by 90 is 0.1 something, 0.11, I'm not sure. So then that's how we will calculate negative likelihood ratio. We want this value to be less than 0.1. So again, 0.01, 0.001, we would say that that's a great negative likelihood ratio. So suppose we got a negative likelihood ratio for a test of 0.01. You would say that that's great. That's really, really good. Minus 0.01. What would that mean? That would mean if you did a test on a patient and it has a negative likelihood ratio of 0.01 and the result came back negative, you are 100 times sure that that test represents a negative result, a true negative result, versus a false negative result. That's exactly what it means. So that's a good thing, because if you're kind of like more sure it's a true negative result, then that test is really good at ruling out the condition. All right, so I'll just pause here now and ask if you all have any questions about the likelihood ratios. Let me see if I have someone posting something. So high sensitivity is, yeah, the person is negative. High specificity is, yeah, the person is positive. Yeah, that's right, Annalise, that's correct. And by extension, we say a high positive predictive value is good at saying, yes, the person has the disease. A high negative predictive value is good at saying, yes, the person does not have the disease. Values. And what we also saying is a high positive likelihood ratio. If it's more than 10, means, yeah, the person have the disease. A negative likelihood ratio, if it's less than 0.1, says, no, the person does not have the disease. Now, what I would say is positive likelihood ratio and negative likelihood ratio are calculated from sensitivity and specificity. So generally, these values depend on sensitivity and specificity. But the predictive values could vary depending on the prevalence of the disease. So if a condition is really, really, really common and you test for it, what tends to happen, because the condition is really, really prevalent, the positive predictive value tends to go up. And if you test for a disease that's really, really rare, what the effect that has on negative predictive value is it tends to raise the negative predictive value. So predictive values actually vary with the prevalence of a condition. Some diseases, when we test for it in certain populations, the prevalence of the condition is very different compared to other settings. Take, for example, chest pain. About 30% of people presenting with acute chest pain, this is one of the topics you are talking about next week, about 30%, 1 in 3 patients presenting with acute chest pain in the emergency room going to have a heart attack or acute coronary syndrome, 1 in 3. Whereas if you look at acute chest pain coming into the health center, coming into primary care, which is what you're talking about and focusing on next week, If you look at the percentage of people coming in with acute chest pain in the health center, it's way, way less than 30%. Probably 5% or 2% of the people coming in with acute chest pain in the health center actually is having a heart attack. So if you had some sort of test and you would use that test in the emergency room, and all of a sudden now come and use it in the health center where the prevalence of the condition is much less, what would happen is the negative predictive value for that test would go up and the positive predictive value for that test would actually go down. Because increasing prevalences of a disease raise predictive value, positive predictive value, and lowers negative predictive value, and decreasing prevalence of a disease raises negative predictive value and lowers positive predictive value. That's just an extra bit I have to say about predictive values. Not so much something we'll test you all on, but it's good to know and understand more or less. So let's, with that, go into an example. So this brings us to our first little break, but it's a little break where you all actually going to work something out, and this is what you're all going to work out. Let's say we want to see if, again, I choose something topical, try to make it relevant, COVID-19. There is lots of research going on now, lots of diagnostic tests of accuracy, lots of DTA studies or lots of diagnostic studies actually going on now for COVID-19 to see how we could diagnose it. Of course, you all know the people that got diagnosed, got this thing, got a nasal swab, and the nasal swab does PCR, polymerase chain reaction, and it multiplies the DNA or the RNA, I believe, for COVID-19, and it detects it. It's expensive. It's only done in certain fancy labs. So why we can't do an antibody to see if people have the condition? Antibody, just take a person, do a blood test, within probably a few hours to get a result from the lab. So they're actually doing research like this actually all over the world right now. They're taking people who have COVID or could have COVID, and they're subjecting everybody to PCR testing and nasal swab, and then they're subjecting everyone to a blood test to see how the blood test, the antibody as the index test, would measure up against PCR, the gold standard, to see if you have the disease. This is not real data, it's fictitious data, but what I'll say is the result probably mirrors what is the actual result for antibodies in diagnosing viral infections in general. So what it is I want you all to do is, using the data on this slide, I want you all to work out the 6 measures. I want you all to work out sensitivity, specificity, positive and negative predictive values, and positive and negative likelihood ratios. Right, so I'll give you all a little break now to do that. Let's take like about 10 minutes. And of course, you could refer to the presentation, which hopefully you have on your device, to go back to the slides that tells you how to calculate the relevant bits with the equations and whatnot. And we'll come back in 10 minutes time to see what answers you all came up with. All right, so 10 minutes, work this out. Okay, guys, I'm back. How things went with this calculation? You all think you're able to figure out the values? What I would say is there are calculators that could sometimes help with these calculations that you could use to verify your answer. So I intentionally did not give you the calculators that could be used before, because I wanted you to be able to calculate it and work it out. But what I'll do, I'll just post it an example of such a calculator that you could use in the chat. So if you go to the chat, you'll see the link to the calculator that could be used to work out the values for this. And if you use that calculator to verify answers, you'll see what you should have gotten was, let me see, it was a sensitivity of 60%, 0.6, a specificity of 95%, 0.95, a positive predictive value of 0.923 or 92%, a negative predictive value of 0.704 or 70%, a positive likelihood ratio of 12, 1, 2, and a negative likelihood ratio of 0.421. So I don't know if you all got answers at least close to resembling that. You all got those answers? Yeah, all right, General. Some people at least got those answers. Anyone got different answers or confused about any of the measures? I mean, it's not too hard to figure out. We could do it right here on the slide. So sensitivity will be 60 over 100, 60 over the total. Sensitivity, specificity would be 95 over this total, 95 out of 100. Positive predictive value will be 60 out of 65. Negative predictive value will be 95 out of 135. Work that out. And based on the sensitivity and specificity you get, then you'll be able to calculate the likelihood ratios. So based on that and based on these measures, um, how your comment on this test? I see someone said they got a negative likelihood ratio of 99.4. That's Annalise. So most likely, Annalise, the reason that happens is when people do the calculations, they mix up percentage signs with fractions. So in this case, the negative likelihood ratio should be what? The false negative rate, which should be 0.4, right? Divided by the true negative rate, which is 0.95. So 0.4 out of 0.95. Now, if you say 0.4 out of 95%, or 0.4 out of 95, you might get a wrong answer. Or if you switch it around and use different numbers. But you could go back and verify and look at it. Usually the reason why people get the likelihood ratios wrong is because they make a mistake with the fractions and the percentages, right? So in this example, looking at the values you all got, comment on the usefulness of this antibody test. What do you think this antibody test is going to be used for? It's very, if you go back to the measures, is it sensitive, specific, both? Sensitivity and specificity. Some people say ruling in, yes, that's right. So if it's very specific, then it's good at rule it in, but it's not very sensitive, so you can't use it to rule out. If the positive predictive value is high, you're thinking it's good at ruling in, but the negative predictive value into all that, so you can't rule out. And if the positive likelihood ratio is more than 10, then you have to say yeah, good at ruling in. But if the negative likelihood ratio is not less than 0.1, then it can't really say it's good at ruling out. So actually all the measures, the 3 pairs of measures, actually kind of tells us this good at ruling in. And actually that's the case for antibody testing when we try to use antibody testing to diagnose viral illnesses. You all would know this and appreciate this from immunology because it takes a while for your body to make antibodies. It takes a while for your body to make IgM and eventually for it to switch to IgG. In the case of COVID-19, that is no exception. They have shown that people convert after probably, on average, probably 2 weeks from the onset of symptoms. But if a person now comes within 5 days and they got COVID 5 days ago and they are infected, the PCR going to be positive, but the antibody test going to be negative. So what it means is generally we cannot use these antibodies to rule out that the person has current infection. But if the antibody tests are positive, you could generally use it to rule in and say, yeah, well, we think you have the condition. And that's probably the case for antibodies in general when we use them to diagnose viral illnesses, right? So a C analyst got a clarification for the calculation, right? So it's 100 minus 60, as we pointed out. You have to remember and work that out first, the numerator in brackets. So in terms of the next thing that we'll see, just wrapping up on diagnosis now, I intentionally spent more time on diagnosis because that's the next big thing I want you all to be able to work out and understand. Most of the exam questions and in terms of the calculations you're going to get for exams, both the exams and quizzes in this clerkship, as well as EMA final MBBS exam, going to be on what we spoke about yesterday, treatment, and a lot of what we spoke about today, diagnosis. Actually, a diagnostic study table like this came for the last MBBS exam. So you have to be able to work out the calculations based on this thing. The other thing I would say as we wrap up diagnosis is with this thing called the pretest probability. The pretest probability, as the word suggests, before you test the person, the probability that the person has the disease. And the point I'm just making here is that pretest probability and disease prevalence is roughly the same. Suppose I told you that I had 100 patients coming in and 100 patients coming in with chest pain. And suppose I told you I knew in patients like these 100 patients that I have that they are high risk for heart disease and 30% of them develop heart attacks, right? So suppose 30% of patients like this develop heart attacks, complaining of chest pain. From the time a person like that comes into your office and they say, Doc, my chest hurting, you know that that person is starting off at a 30% chance of having an MI. That is what we call the pretest probability, and it's the same as the disease prevalence. The concept of pretest probability we use a lot in diagnostic testing because some conditions, if the person coming into you before you test them and they have a high likelihood of having the disease, it influences what kind of test we do and how we use sensitivity or specificity. Again, some conditions come into you and the chance of the person having the condition is really, really rare. And sometimes because a condition is really, really rare, it sometimes can influence the result of a diagnostic test that you use on that person. So prevalence and pretest probability is likely the same. In the same way, you could work out something called a post-test probability, which as you could probably figure out from the meaning of the word, post-test, after you apply a test to the person, was the chance that they now have the disease. But that is a little bit beyond the scope of this presentation for you guys, so I wouldn't delve into that further. What I'll conclude by saying is showing some likelihood ratios for you all to interpret. So look at this. These are some positive likelihood ratios for some tests that we could when a person come and complain of chest pain. Now, I've been using the word test all along since we started chatting this morning, and I'm referring to things like the dimers and antibodies and all these things. But what it is I would like to just clarify is that when we say a test isn't anything really that has to be something done in a lab. It could be an X-ray, it could be an ECG, it could be a stress test. It could also be a question you ask the person on history. It could also be an examination finding. So what the slide kind of, the point the slide kind of emphasizes is a test doesn't always have to be a test in the true sense or in the sense that how you thought about a test before, like a laboratory test or investigation. A test could be, you tell the person, describe the chest pain to me. You know, and the person said the chest pain was squeezing it, feel like somebody rest 10 concrete blocks in the middle of my chest. That's what patients actually say have an MI. So from the time a person give a description like that, or you ask the person describe the nature of your chest pain, you actually testing a patient. From the time you examine a person and you press the chest to elicit tenderness or you listen to the lung and heart sounds, you're really testing the patient. So a test is not only an investigation, a test could also be a history finding or an examination finding, just to clarify at this point in time. So what they have done is they have worked out the diagnostic properties of history findings and examination findings. They have taken things like the nature of chest pain and they have worked out If a person complains of chest pain of a particular nature, can we use that to say they have a heart attack or not? Or they have used things like, if when you listen to a person's chest, you hear a gallop rhythm. A gallop rhythm is a certain kind of character of the heartbeat. The person tachycardic, as you all probably know, who having heart failure. If we hear a gallop rhythm, what's the sensitivity and specificity of a rhythm in diagnosing heart failure? So testing is not only limited to a test or investigation. That's the main point. But looking at this slide, what you think about the likelihood ratios? Which one really good? We said the positive likelihood ratio is good if it's more than 10. You could see an exercise stress test, an exercise ECG is 10, which is kind of just cutting it. When a person gives a typical history of cardiac pain, pressing, squeezing pain in the middle of my chest, the positive likelihood ratio is 100. Is that good? That's very good. That means you're kind of thinking from the time a person complains or something like that, chest pain of that nature, you're kind of thinking, well, this person could really be having a heart attack. Even before you diagnose the heart attack in the gold standard way, even before you examine the patient, even before you take the ECG, even before you test the troponins, the CKMB, the biomarkers, which is how we diagnose an MI, from the time the person give a typical history, you're kind of thinking, will this person have the disease? So looking at it, you can see that sometimes a history finding has more diagnostic value than a test, as shown here in this example. And the last one I'll conclude with is these are likelihood ratios for hyperthyroidism. I would say specifically for Graves' disease, that's the type of hyperthyroidism this is. You all would know or have an idea of Graves' disease, one of your last PBL problems. So these are the different signs that could be or could not be seen in Graves' disease. And the plus refers to the positive likelihood ratio and the negative refers to the negative likelihood ratios. So based on this, what does that mean? You could see that eyelid retraction, you could see that eyelid lag and fine finger tremor all have positive likelihood ratios more than 10. That means if a person have these signs, eyelid lag, eyelid retraction, fine finger tremor, you're thinking there's a high chance this person probably really has Graves' disease. Whereas the other signs, if a person have them, the positive likelihood ratios ain't all that great. So you can't really say if a person has an enlarged thyroid, if a person has a goiter, is Graves' disease they have. You all may know it have other conditions that could make your thyroid gland swell up. It have other things that could cause a goiter. So an enlarged thyroid gland by itself is not diagnostic of Graves' disease. Look at the negative likelihood ratios. They all more than 0.1. The only one that's probably kind of close, just cutting it, is an enlarged thyroid, which has a negative likelihood ratio of 0.1. So what does that mean? It means that an enlarged thyroid has a good negative likelihood ratio. So if a person does not have an enlarged thyroid gland, if a person does not have a goiter, you could kind of be confident in thinking this person does not have Graves' disease. Right? So the absence of the goiter is probably more diagnostic in the sense that it's more sensitive in making and ruling out Graves' disease than it is in ruling in Graves' disease. That's how we would use it in practice. Right? So that in a nutshell really is just some examples to emphasize the point. And this brings us to the end for diagnosis. So I'll just pause now and ask if you all have any questions about diagnosis and what we spoke about so far for diagnosis. Any questions about diagnosis, the calculations, what I mean? The main thing I want you all to get from it is really the table, how to calculate the values and how to interpret the values. That is what you'll probably need to do for the rest of your medical careers in terms of interpretation. All right, so if no questions, the other bits that we need to speak about today is systematic reviews, case control, cohort studies, and then we'll say something about validity. So each one of those topics is really mini topics we're going into now. Each one of those is like probably about 10 minutes. So we probably have probably about maybe 35, 40 minutes to discuss those topics. So I don't know if you all feel you need a break before we go into that, or if you all want me to press ahead and go ahead one time. Tell me what you all prefer. You all need a break, or you all want me to go right into the other mini topics? It's about 40 minutes. 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 40 minutes All right. Okay. All right. So people saying continue, right? So again, I know it's a lot. Online classes, the disadvantage with online classes, I know your attention span tends to fall a little bit after a while. But at least the good thing is we're recording, right? So you could always go back to clarify any points that you think you may have missed if you missed it now looking at the class live. So we'll go ahead. So what is this thing called a systematic review? Who remembers where a systematic review and a meta-analysis was in the hierarchy of evidence? In terms of the hierarchy of evidence, a systematic review was where? Remember where? Anyone? We spoke about that a whole day ago. All right, yes, right. So people remember it was at the top. So a systematic review and a meta-analysis is the study of greatest strength in medicine. So, I mean, that's a big statement because if you want to know if a particular treatment works, what you should look for is a systematic review of all the studies on that particular treatment. That is what I would look for. So you just need to understand really what a systematic review is and what it tries to do. And that is really what I'll just be discussing. What a systematic review is and what it tries to do. But as you'll see, it's described here that a systematic review is a study on other studies. So why does you want to do a study on other studies? A systematic review does not involve taking a group of patients and giving them a treatment and giving some people placebo. It does not take a group of people to see if a test is accurate. It doesn't take patients at all. A systematic review, as the word suggests, is a review, meaning you look at past articles and past studies that have been published. So it's a study on other studies. And it was this guy's thinking, Eddie Cochrane, who founded what we would know as the Cochrane collaboration. It was this guy who actually thought, well, we cannot practice medicine based on one study. If someone did one RCT and they said the treatment works, it doesn't necessarily mean that the treatment really works. And you might kind of be wondering, well, why is that the case? Well, we cannot practice medicine based on one study because it could be that that study was flawed. We saw that it have a few biases or problems or things that could go wrong in RCTs. So we cannot practice medicine based actually on one study. Suppose the study showed findings out of chance. Suppose the study was a poorly designed study. Suppose there are other studies that actually is telling the truth, but we could not find those studies. So what a systematic review tries to do, it looks at all the studies that are published, but what it also tries to do, it looks for all the studies that are not published. That is really what a systematic review tries to accomplish. Suppose I told you, let's pick an example. Again, an example with COVID. There's lots of ongoing research. We saw some examples yesterday. Suppose some people want to know if this drug that we picked, Plaquenil, hydroxychloroquine, does hydroxychloroquine really help patients with COVID? If I asked that question, and I looked at one particular RCT yesterday, the results of an actual RCT where they showed that there was no difference. But is that necessarily the truth? Suppose there were other RCTs done. Now, what I'll tell you is there may be other RCTs done. Maybe they're not published as yet. Maybe they're completed. Maybe they will not be published. So one of the things that a systematic review tries to overcome is something called publication bias, right? Publication bias really refers to that bias inherent in research where studies that show negative findings tend not to get published. So what does that mean? Negative findings mean the study showed the treatment wasn't better than the placebo. So if a study shows the treatment really wasn't better than the placebo, that in itself, branding it a negative study is a negative thing because nothing is really negative about that. We're just saying that the treatment didn't work. We're not saying that the treatment harmed people or hurt people. So those studies, there's a tendency for journals not to want to publish them. Anytime the treatment isn't better than the placebo, people tend to think, well, I ain't going to publish that in fancy. Believe me, if the studies on COVID showed a particular treatment works with all the hype about COVID, journals would jump at it. They would jump at it and say, yes, this drug works for COVID in this randomized controlled trial done in some part of the world. And journals are actually more likely to publish that than they are to publish studies where the findings were no different. But that is a problem. It's a problem because it means what's published is already slanted to show favor in terms of treatment. So it could be that one study would get published because it showed the treatment worked, but 10 studies done on the same treatment show it did not work and they did not get published. So for that reason, we cannot practice medicine based on one study. One study sometimes does not always give the answer. In medicine, we like to replicate findings. We like to see that if something really is working, we would expect it to work across several studies done in different parts of the world. So that is what a random systematic review tries to do. A systematic review tries to find all the studies of interest to see if this treatment really making a difference. So if I you all find all the studies on hydroxychloroquine for COVID-19, how you would search, how you would go about doing something like that. Yesterday we said the second step in EBM is to find the literature, find the appropriate studies. Sure, you would search Medline, you would search Google Scholar, you would search PubMed. But the problem with searching Google Scholar and PubMed and Medline is you're only going to find studies that are published. You're not going to find studies that are not published. And someone posted in the chat the gray literature, and the gray literature refers to theses that people do for the DM or the PhD. It refers to non-peer-reviewed journals. It refers to sometimes research that is done. And a good classic example would be you guys when you do a year 2 research and you all presented this October last year. That would be a good example at this point of gray literature. I would urge you all and encourage you all to try to publish your research and get it into a journal. But often a lot of students usually when I ask this in class face-to-face, how much are you guys publishing in research you're doing? It usually probably only less than a quarter of the class would raise their hands. And the issue is some of the research you guys do is actually really good and worthy of publication, but you would not publish it for various reasons. So what are the reasons sometimes people do research and don't publish it? Well, what you all think are some of the reasons why you all would do research? And you can talk from personal experience from a year 2 research project, why it is you all would do research, complete it, and it would not get published. You could type in the chat. I want to hear what some of these reasons would be. What you all see as the roadblocks for not publishing your research. Small sample size, right, Annalise, right? So that is often one of the reasons sometimes people feel the research is not worthy of publication. They had too small numbers of people because the time to conduct the research, they couldn't get enough people. It is not always a valid reason not to publish research. Sometimes it could be that your research still could get published. You could probably consider renaming your study a pilot study. And if you pitch it like that, pilot study and the findings of interest, you could still publish it. So that would be the workaround for that, Annalise. Shivani is saying it's expensive. You're most correct, Shivani. Last year, I had collaborated on a research project by one of the cardiologists, by Dr. Sicharan, one of the lecturers in internal medicine. I did the analysis for one of his studies and we got it published. It was something looking at clopidogrel, Plavix, resistance in our population. We got it published in an open access journal, Open Heart, and it costed $2,000 US. It costed 14,000 TT to publish a paper in a journal. Luckily, all the authors, it's probably about 10 of us, we could have like divided it up and shared up the expense and the cost. So it kind of like works out when you share it up and you have lots of authors, but no doubt, Shivani, publication is expensive. It's 2,000 to 3,000 US to publish an article in an open access journal. Now, what open access means, like Open Heart, you can check out that paper, just Google it, clopidogrel resistance in Trinidad. What that open access means is when you read the paper, you actually see the full length, you see the entire paper. But not all journals publish open access. Some of them have the option where you could publish, but only the abstract would show on PubMed, and those generally much cheaper. Some of them possibly even do it even for free. So don't think cost is a barrier to publishing your work. It is a barrier if you want to go open access, but if you're not going open access, it still remains an option. So I don't know if that would solve that barrier for you guys. and you could still consider publishing your research. The other reason students say they don't publish their research is sometimes it takes lots of time and effort to put their research, which they write up like a big report, to put it in a manuscript format. So some of you guys write up big reports, all kind of 5,000, 6,000 words, and to publish something in a journal, it must be 2,500 to 3,000 words. It must only have 3 to 4, 5 figures or tables. You have to edit it, you have to fix the references. That takes time. It takes lots of time, and you need people to help you to do it. It shouldn't be a barrier. At least I tell all my students who I have supervised here to research. I publish all the research eventually that they do, and I'm actually working on a few of them right now with the help of even some interns, people who are post-internship and looking just to improve their CV and get a publication to the name. I have some post-internship people actually helping with the manuscript preparation. So if you all have friends in higher years or people who you know are past graduates, and interested in publication, you could probably work with them to actually help you publish your work. But these are just some of the reasons why we don't publish our work, but mean that our work is not good. At least being a judge from past student presentations, I think the work you guys do is generally of a high quality and it's worthy of publication. It's just my opinion. So a systematic review tries to find all of this. So how is a systematic review supposed to find a research that medical students did on their research day? Or how is a systematic review supposed to find a thesis or research that some DM student did for the final exam? This gray literature could be searched if the libraries have a repository for it. So what we were actually thinking in my unit, as you'll probably know, the research project originates from my unit, the unit of public health and primary care. We were thinking of having repositories of all the medical research in the library. It has been done already. They could find it by going online and creating a little database that people could find. But it is very daunting to find all the published and unpublished literature. How do you find stuff that's not published in your local language? A lot of research isn't published in English. Sure, there are translators you could use. There's Google Translate. You could translate articles. But it could actually be very, very difficult to find studies and find all the studies of interest, both in your language and in other languages as well. The ways you could work around and find unpublished literature is sometimes contacting friends and colleagues too in different places and say, hey, I know you're doing some research on this. Tell me what you found. Tell me about the findings. You could share a report, please. I know it's not published or published yet. I'm doing a systematic review. Let me see what it is you could come up with. So usually when you do a systematic review, you would find a whole set of studies. Published, unpublished, you'll find a whole set. And then you would actually pick all the studies that is relevant to you based on the question that you asking. You pick all the studies that is relevant to you, and you would do what we call a systematic review of those studies and a meta-analysis of those studies. When we say a systematic review, what we mean is part of the systematic review after finding the studies is you try to go through all those studies of interest now you find and put them together and extract the similarities and the conclusions from all of them. When you do a systematic review, often what is done is also this thing called a meta-analysis. A meta-analysis now is what you do when you take all the study findings, the findings from all those studies, and you combine them to generate one major finding. So a meta-analysis is a statistical technique. It's something statistical software does. And it combines the results of many studies to show you one final result. So if let me just say we looked at hazards ratios for hydroxychloroquine effectiveness in COVID-19 and we found 20 RCTs, the meta-analysis would combine and the results from all those 20 RCTs into one result, into one hazard ratio that you could interpret and decide, hey, does this thing really make a difference? What it is I'll share with you all is a systematic review, as you can imagine, is a lot of work because you have to look for studies. Finding them in itself is a task. And when you find these studies, what you have to do is you have to go through all the studies you found and then pick out the ones of interest and then go into detail in all the ones of interest you found. I'm involved in a systematic review with one of my colleagues. She's a rheumatologist. She's a rheumatologist in Jacksonville, Florida. And we embarked on a systematic review and a meta-analysis probably over a year in January 2019. And the topic of our meta-analysis and systematic review, she's a rheumatologist, so she diagnoses conditions like Sjogren's disease, which is an autoimmune condition that affects the salivary glands. And the review question we had was about the diagnosis of Sjogren's syndrome. I'm not sure if you all know about the diagnosis of Sjogren's syndrome, but sometimes it involves invasive testing. You have to do a biopsy of the minor salivary glands in your lip, or sometimes you have to do an invasive test where you test salivary flow in the salivary ducts and glands, which involves invasive testing. And the question they asked was, can we use ultrasound to diagnose Sjogren's syndrome? It has been an active area of research for the last 15 years. There have been other reviews published on the topic, and we decided to update the review. So just to give an example of that review, when we did the initial search, we came up with 400 articles. So we had to go through independently 400 articles each to decide which ones were of relevance. And out of the ones we felt were relevant, we had to pick, we ended up with 65. And out of the 65, we picked 54 of them had enough data for us to do a meta-analysis. So we had to go into the 54 articles in detail, extract a whole set of information, and then combine them in a meta-analysis. It was a lot of work. We started in January 2019, and we now completed writing the manuscript almost a year and a half later. It takes a lot of work to do a systematic review, but it's worth it because when you do a systematic review, the conclusions you're going to get is what you're going to use to practice medicine with. This is what a meta-analysis looks like. You'll probably have had relatives ask you, I hear people say, Doc, I could take garlic for my blood pressure. I have patients that ask me that all the time, and I have patients that tell me, Doc, you know, I think my pressure was high. I went and chewed 2 grains of garlic, and I think it went down after. Does garlic really reduce blood pressure? That's a question of what? It's a question of treatment. So if you want to know, we could look for an RCT, but you could bet there have been many RCTs done. And if there are many RCTs done, we could do a systematic review of those RCTs. And that is what this actually is showing. This is a systematic review and a meta-analysis of garlic and its effect on blood pressure. So how we interpret this? This, of course, was done by looking at several studies, and you can see the studies listed on the left-hand side. So all these are the authors of the studies, probably about 15 studies. And with these horizontal lines with the squares in them, the horizontal lines with the squares in them is the actual result. So the result was something that they calculated, something called the WMD, the weighted mean difference. You could think about the weighted mean difference as kind of like an absolute risk reduction. It's not the same thing, but it's similar enough, absolute risk reduction. And we would say that a study, if it found no difference, would have an absolute risk reduction of 0. In the same way, weighted mean difference is interpreted the same way. If the weighted mean difference is 0, it means the average blood pressure reduction between both groups, take one and minus the other, was 0. If you get 0, it means the treatment wasn't working. If you did not get 0, it means the treatment was working. Each one of these lines represent the confidence interval for the difference and the finding. As you'll see that this study, actually, the confidence interval doesn't include 0, because we see in here this vertical line of 0. This vertical line is what you'll see on all meta-analyses for treatment, and is usually the line of no effect. So this first study, the confidence interval minus 14 to minus 5, it does not include 0. This study showed that, yes, garlic reduced blood pressure, and it did it significantly so. But this study, second study, you see in the line touching this vertical line. You see in the line touching this vertical line as 0. So that means the second line, the confidence interval include the value 0, and you could confirm minus 22 to 0.33. This study found no difference. So based on that, you could say this study found no difference for garlic and blood pressure. This one found no difference. This one found no difference. A lot of these found no differences. This one here found a difference. This one here found a difference. This one up here found a difference. So what they do, they combine all these studies, and overall, when they combine all these studies, what they show here, this diamond represents the overall result. So this diamond, does this diamond include the value of no effect? Does it touch this line of 0? No. This diamond is minus 5 to minus 2. So this line tells us that overall, all these studies, when you combine them, showed that overall garlic reduced blood pressure by a tiny amount. It reduced it by probably 2 to 3 millimeters of mercury. Now, definitely statistically significant. The meta-analysis says garlic reduces blood pressure, but yesterday we highlighted that point of clinical significance. If it reduced blood pressure by a certain amount, in this case it was what, 3.75 millimeters of mercury, you have to decide now, well, does it make sense I giving garlic to my patient? If a patient blood pressure is 160 over 110 and you give them garlic, this is for the systolic blood pressure, the systolic blood pressure will drop from 160 to 154. Is that a big enough difference for us to say garlic works? Unfortunately for garlic, it's probably not. So we can't say take garlic because of your blood pressure. You need to take your medications. But this was one example of a meta-analysis done. Here is another. This one was the risk of omega-3, 6, and 9 fatty acids or fish oils and major vascular events. So what does this show? This really showing that compared to placebo, people taking omega-3, 6, and 9 fish oils, ask any question, does it prevent people from getting heart attacks and strokes? Again, I have patients that ask me almost every week. I say, Doc, I take Omega XL. Can I continue taking Omega XL? I think these guys do a good job at advertising and marketing on TV because everybody takes Omega XL for all kind of things. They take it for foot pain, they take it for arthritis, they take it for cholesterol, they take it for heart because these guys do such a good job at promotion and TV. But does it make a difference? Does it prevent heart attacks and strokes? That is what this meta-analysis actually tells us. So how we interpret this meta-analysis? We're going to see that there are lots of studies, and this meta-analysis are actually 3 meta-analyses actually, because if you see it, if you look at it closer, if you can make it out on your screen, this meta-analysis looked at, let's see if I can make it a little bigger. It looked at coronary heart disease, it looked at stroke, and it looked at the need for revascularization, the need to get coronary artery bypass grafting or stenting. But you could just glance the meta-analyses and interpret it. So what we see in here, we see in here this line of 1 is a rate ratio. This is the relative risk. A relative risk of 1 means there is no difference between the groups. And if the confidence interval include a value of 1, we could say there is no difference between the groups. So if we look at coronary heart disease, we would see here the diamond shows the overall effect. The diamond includes the value 1.9 to 1.01. So it means omega-3, 6, and 9 doesn't help people with coronary heart disease. Does it prevent stroke? We could just glance here and just look at the diamond. The diamond crosses this vertical line. It includes the value of 1 for relative risk, 0.93 to 1.1. No effect. We could say the same thing for revascularization and for any major event. When they looked at all combined, we see in here 0.93 to 1.1. This overall diamond shows no significant effect. So we could confidently say that these fish oils don't make any difference overall for vascular events in terms of preventing it. So when my patients ask me, I could tell them, well, studies have shown that overall these supplements don't make a difference. You probably wouldn't benefit much from taking it. It probably wouldn't do any harm apart from hurt your pocket because patients complain that sometimes these fish oils are expensive to buy. It mightn't do harm, but at the same time, it wouldn't give any benefit. So that is what this meta-analysis shows. And you could think about it. You could ask any question about treatment. Chances are someone have done a systematic review and meta-analysis of randomized controlled trials to tell us what to do in medicine. So for systematic reviews, remember you said this is brief. It allows to generalize the findings of many studies to generate one final conclusion. That's what a systematic review does, and that is why it's so strong, because it looks at many, many studies to tell us what to do really for patients to treat them. And a meta-analysis is this statistical method where you combine results looking like this in this thing called a forest plot or a meta-analysis, and this is really what they show. So any questions about systematic reviews? That's all we'll say about systematic reviews. I just wanted you all to just appreciate why it's at the top in the hierarchy of evidence and why it actually really dictates what we do. Actually, all the guidelines for us to practice, if you want to know how to do or treat anything, how to treat a heart attack, how to treat appendicitis, how was the best way to deliver a baby, all the questions you all would have and see when you do your clinical medicine rotations, and even the content that you would learn in your face-to-face, in your didactic sessions, Everything we do in medicine, most of it is actually based on systematic reviews. You want to know is the best way to treat hypertension? A systematic review actually tells us what's the best treatment to give. So any questions about systematic reviews before we move on? I know I've seen some people done a systematic review, which I thought was most applaudable medical students for their research. They did a systematic review of the literature. They did not do a meta-analysis, but they did a systematic review, which in itself was a very good and commendable effort. So if no questions about systematic reviews, the other two main study types we just need to speak about would be this one about prognosis. Patients often ask this question, and they ask me this question, say, Doc, what's going to happen? I have patients and I tell them things like, well, we calculated your kidney function, your estimated GFR is 45%. So I told patients that. I had patients, get really sad, break down, start to cry. They said, Doctor, tell me my kidney function is 45%. That sounds really bad. What does this mean? What's going to happen to me now? Does this mean I have to go on dialysis, or does it mean I will need dialysis soon? So this is just one example of the question a patient asked me. And what the patient is really asking us about is prognosis. They ask us if they have a certain risk factor, if they have a certain condition, what's going to happen to them. One of the studies that allows us to figure this out in medicine is what we call cohort studies. Cohort studies, if you remember in the hierarchy of evidence, it was CIS reviews, RCTs, and below RCTs was cohort studies. So it's not all that strong in the hierarchy of evidence compared to the others. It's definitely better than some of the other study types below, but cohort studies tell us about prognosis. If a person has a particular risk factor, what it is going to happen to that patient. What will be the outcome if a person has a particular risk factor? Look at this example. A routine examination, you detect a grade 2 murmur in a 9-year-old boy. He admits to episodes of fatigue, difficulty completing sports. He had an echocardiogram and they reported that this boy has a bicuspid aortic valve. You remember your anatomy and the cardiology in terms of anatomy heart. The bicuspid aortic valve is an abnormal valve. A tricuspid aortic valve is what the normal valve is. And they reported because this boy has a bicuspid aortic valve, he's going to develop this thing called heart failure. So what would be the answerable question you could get from this scenario? Remember the first step in EBM? The first step in EBM is to ask an answerable question. And how we phrase that question? We phrase that question in PICO. So what's the PICO question for this scenario? In a 9-year-old boy, that's the P. Does having a bicuspid aortic valve, that's the I, compared to a normal aortic valve or tricuspid aortic valve, that's the lead to the outcome of heart failure. So the PICO for a prognosis or a cohort type study or question, the PICO, the I and the C are just risk factors. We could ask many PICOs. In an adult, does smoking compared to no smoking lead to lung cancer? In an adult, does having high cholesterol compared to low cholesterol lead to development of stroke? So these are examples of PICO questions that we could ask for cohort studies, and we'll see it's the same actually for case control studies as well, because cohort studies, like case control studies, try to link a risk factor with disease. Now, how we could figure this out in real life? Unfortunately, when we think about risk factors, we can't randomize a person to a risk factor. I can't take 100 children and randomize 50 of them to bicuspid aortic valve and randomize the other 50 to a normal aortic valve. They already have the valve inside them when they were born. I can't change that risk factor. In this example, the risk factor is not something that we could modify. Some risk factors, sure, we could modify, but when we talk about risk factors, we can't randomize people to risk factors. So we can't do a RCT to answer the question about risk factors. If we had to figure out if smoking causes lung cancer, I can take a group of non-smokers and randomize them to begin to smoke and randomize the other half to say, remain off the cigarettes, don't smoke. It would be unethical. So the next best thing we could do when a person already has a risk factor is simply follow them up over time and see what's going to happen with them. And that is really what a cohort study tries to do. Shown in this graphic, what you're seeing here is 5 people, they are smokers. You follow them up over time. 3 out of 5 of them, or 60% of them, get sick. Here we have a group of non-smokers. You follow them up over time. we see one of them out of the 5 people get sick, 20%. So what you could see more people here getting sick in the smokers compared to this group. Actually, 3 times more people getting sick in the smokers compared to the non-smokers. So then you might be tempted to say, well, smoking makes people 3 times more sick. But the problem with drawing that conclusion is, could there be some other factor that the smokers have that making them sick that the non-smokers do not have? Suppose the smokers are people who don't bother to visit a doctor, don't check the cholesterol levels, don't exercise, have high cholesterol levels. That could be the reason they're getting sick if you're looking at MI. That could be the reason for the MI and not so much the smoking. And the non-smokers could be people who generally try to live a healthy life. They watch their weight, they try to eat healthy and exercise. They go to the doctor, they do the blood test to check for certain things. And that would be the reason why these people not getting sick. So that's one of the problems with a cohort study. When you try to follow people up over time who already have a risk factor, other risk factors tend to go with the risk factor you investigate and of interest. And we'll see that later as we'll end by discussing what confounding is. We'll see that that's a classic example of confounding. And this is what the analysis of a cohort study would look like. Let's see, we had a group of smokers. Let's say we followed up 100 smokers over a period of time. And then we compared it to 100 non-smokers. If we looked at 100 smokers, 40 of them developed lung cancer. Let's say we follow them up over a period of 30 years. 40 of them develop lung cancer. So we could say 40% of smokers develop lung cancer. I'm not saying that is actually the case. This, of course, is just fictitious data for an example. And non-smokers, suppose we said 20% of non-smokers develop lung cancer. Again, that's not the reality. The prevalence is much, much, much less. But again, just for this example, then we'll say 20% of non-smokers develop cancer. So we have 2 event rates. What we could do with these 2 event rates, we could do the same thing we did for a randomized controlled trial. We could take one and divide it by the other. And if we take one and divide it by the other, we get the relative risk ratio, or simply the relative risk. In this case, 40 divided by 20 is 2. So what does 2 mean? Simple to interpret, just like how we interpreted relative risk for RCT. It simply means smokers have twice as much lung cancer compared to non-smokers. So then would you think that smoking increases the risk of lung cancer? Yeah, sure, you would think that. But before you come to that conclusion from a cohort study, you would really need to see that there are other factors that go with smoking that could be making people get lung cancer compared to non-smokers, and adjust and cater for that. And you could bet the interpretation for a cohort study, the interpretation of this relative risk is no different than the interpretation of relative risk that we saw yesterday. If the confidence interval for the relative risk scheme for a cohort study includes the value 1, then we say no significant association. The risk factor is not associated with disease. If the confidence interval does not include the value 1, then there is an association. If the relative risk in that case is more than 1, you would say this risk factor actually making people get sick, the risk factor increasing the chance that people will get ill. If the relative risk is less than 1 and the confidence interval for it is significant, then you would say, well, this risk factor actually is protective, is saving people from getting sick. So the interpretation of relative risk is the same as the interpretation of relative risk we saw yesterday. It's just that the design of the study is a little bit different. Here, yesterday, we saw people were randomized to a group to get a particular intervention compared to a control. This here now is not intervention and control. This here is people with a risk factor and people without a risk factor followed up over time. Right, and that's all I really have to say about cohort studies. Those are the basic things I want you all to know. Any questions about cohort studies? Just for some cohort study trivia, just FYI, so you all know for your information. Does anyone know of a cohort study that was done in Trinidad? Anyone heard about cohort studies done in Trinidad? In the 1960s into the 70s, there was a cohort study done in Trinidad, and it was a landmark study because it was the first cohort study that was done, or at least the first cohort study that was done and published in Trinidad. And they followed up a group of people in a particular community in Trinidad, and they measured risk factors for heart disease. and they followed these people up over time, over at least about 10 plus years. If you all never heard about it, you should be familiar with it. It's good for historic interest and just to know what literature has been done locally in your own setting. And that study was called the St. James Survey. And as the name suggests, the St. James Survey was a cohort study that was done in Trinidad back in the 1960s and 70s. And not surprisingly, the St. James Survey showed that being male, smoking, having a high total cholesterol, having a low HDL, having diabetes, all were factors that increase the chance that people would actually develop heart attacks and strokes. So studies like that have been done in other parts of the world. You all probably may have heard about the Framingham study. The Framingham study was that landmark cohort study that was done in the 1950s in the US. And the Framingham study was that cohort study that again showed the link between all these risk factors and heart disease. Before the 1950s, it actually probably wasn't too clear, and we were probably kind of uncertain as to why people were getting heart attacks and strokes. Heart attacks and strokes have been the #1 cause of death since 1900s and has been increasing worldwide. But it would take probably 50 years before we actually figured out the risk factors for heart disease. So thanks to cohort studies, we know risk factors for heart disease, and we could try to take preventative steps. So if no questions about cohort studies, we'll go straight into case control studies. So that's the last type study that I'll say something about. I'll say something about case control studies. I'll mention cross-sectional studies, and then we'll end by something called, we'll look at validity. We'll end by talking about validity, the threats to validity, which we alluded to yesterday. So with a case control study. A case control study does this. It takes a group of people who have the disease. These are cases. Then it takes a group of people who do not have the disease, the controls, and then it asks these people questions about the risk factor for having the disease in the past. So in a case control study, the disease has already occurred. So just now I showed an example of a cohort study where we looked at a group of people. Some of them smoked, some of them didn't smoke. We follow them up over 30 years, and then we see who developed lung cancer. Now, the problem with a cohort study is they had to follow people over time, and that, of course, takes time. Whereas a case control study, the case control equivalent of that study would be, you pick a group of cases now, today, who have lung cancer. You pick a group of people who are controls, meaning people who do not have lung cancer. And then you ask each group of people questions about if they smoked in the past. Right? So you'll get that. That would be the difference between a case control study and a cohort study. A cohort study begins with people with the risk factor, and it follows them up to see who getting the disease. A case control study begins with people who have the disease, and it's looking back to see if people had the risk factor. Right? There's a difference. So a cohort study compares people who have the exposure against people who do not have the exposure. It compares the risk factor against no risk factor, whereas a case control study compares the diseased against the non-diseased. Those are the two groups, right? So it's a bit different. That is what a case control study do. So you can imagine the reason for doing this. A case control study then would be easy to do. Instead of I following up a group of people for 30 years, I don't have to follow up people for 30 years in a cohort study. What I just need to do is grab a group of people who have the disease now and look back, probably look back 30 years and ask them about risk factors. So a case control study is much easier to do, but if you remember the hierarchy of evidence, it's actually below a cohort study. And the reason it's below, the strength of evidence is actually much less, is because it's actually prone to much more confounding, which is what we'll see in a few slides. So with a case control study, by definition, a case control study is retrospective. It's retrospective because the disease has already occurred, and you're looking back to see if the people have the risk factor. A retrospective study generally is a study where the investigator appears or the researcher appears after the disease has occurred. In a cohort study, the disease has not occurred. So in a prospective cohort study, you appear, the disease hasn't occurred, you follow up people to see if they got it. In a case control study, the disease has already occurred. The investigator appears after that has happened. So he's now looking back to see what risk factors people have. So it's retrospective. So what you do in a case control study is you would usually pick a group of cases, In the example I gave just now, you could pick 100 people with lung cancer. Where you will get people with lung cancer from now? You'll get them from the thoracic clinic. You'll get them in the cancer registry. You might get them at St. James Medical Facility who's seen cancer patients. You'll pick 100 people with lung cancer. And then where you'll get the controls from? The controls should also come from the same place the cases came from. So if the cases came from the hospital, the control should also come from the hospital. But the control should be people who do not have the disease of interest. So you could pick a control from the same hospital that a lung cancer case came from, but the control, you should make sure that that person is lung cancer free. So the controls you pick, and you pick a group of controls through a process called matching. And there are different ways you could match. I mean, I'll just give you one example. If you have a 60-year-old man with lung cancer, the control should also be a 60-year-old man without lung cancer. And that's what they would do in practice when they do case control studies. You could imagine the benefit of a case control study is really useful if the inducing period is long. Meaning, if a person has to get a risk factor for 30 years before they develop a disease, in a case control study, you don't have to wait 30 years to see the people develop the disease. You could bet it's relatively inexpensive, it's cheap, you don't have to take so long a time to do it. And it's good in understanding new diseases. So anytime we get new diseases, COVID-19, swine flu, all these new diseases that prop up, what is often done is a case control study. It's commonly used in outbreak investigations. You all will do outbreaks in year 5 when you go to a public health rotation. And case control studies are good to find out rare diseases. If there's some rare disease and we don't know what causing this rare disease, case control study is generally good for that. But the disadvantage with a case control study is people cannot often remember their risk factors. And what we call that? We call that recall bias. Recall bias essentially means if you have a person who smokes, and a person who has lung cancer, and you were to ask them, well, tell me, did you smoke for the last 30 years? The person might say, yeah, but how it is you going to prove that? You can't prove that. You have to take the person's word for it. Even if the person say, yeah, doc, I smoke about half a pack a day, how it is you're going to validate that information? There is no easy way for you to prove that a person smoked half a pack exactly a day for the last 30 years. So the problem with a case control study is you cannot often measure the risk factor accurately when you try to measure the risk factor retrospectively, because the risk factor was in the past. You have to have really good evidence that the risk factor occurred or not. Sometimes this is the case if the risk factor was something like use of a drug, and the use of the drug was something documented by a prescription, or you could go back to notes to see that the doctor did prescribe it, or you could go to physician notes to see if the physician was accurately documenting if the person drank alcohol, how much they drink, if they smoked, how much they smoke, if they used to exercise. You would really depend on people to document this in the past. But the problem with a case control study is you can't often get that information accurately. You should know some historic discoveries. 1950s, smoking and lung cancer. It's very ironic that the link between smoking and lung cancer was first proved in doctors. The British doctors study. The British doctors study showed that British doctors who smoked were more likely to die from lung cancer compared to persons who do not smoke. You all will learn in ONG that when you give people estrogens only, it could stimulate the endometrium and develop endometrial cancer. When you'll go to a pediatric rotation, you'll see that we do not give children with a fever aspirin. I think you would have encountered this too in the past in year 3, because aspirin is associated with Ray's syndrome. The second one here was an interesting one. In the 1980s, we saw a few dozen women dying from toxic shock syndrome. Toxic shock syndrome is a potentially lethal condition, and young women in the early 20s in age in the 1980s just presented to several emergency rooms in the US and died. A few dozen women lost their lives. And they had no clue why these women developed toxic shock syndrome. They weren't immunocompromised. They weren't ill with anything else before. They were previously healthy and well. So they realized this was like an outbreak of toxic shock syndrome, and part of an outbreak investigation involves doing a case control study. And when they did the case control study, they found that in the cases, the women with the syndrome, they were more likely to report using tampons from a particular manufacturer compared to the key controls, the women who did not have toxic shock syndrome. And because of that, they were able to actually trace a particular brand and a particular manufacturer had actually just started manufacturing tampons, and the material they were using was harboring the staphylococcal organism, which was actually resulting in toxic shock syndrome and killing these women. So thanks to a case control study and outbreak investigation, they were able to pinpoint who the manufacturer was, close them down, shut them down. And to this day, when you read about toxic shock syndrome, although it's caused by bacteria, you would still see in terms of the cause, it could be tampon related or not tampon related, which is something you need to ask your patients about in the rare instance you see a patient with toxic shock syndrome. So what does the analysis look like for a case control study? Remember we said the case control study is disease versus non-diseased. In the RCT and cohort, what we saw here, we saw exposed versus non-exposed. So note this table is different. Here we see the exposure now is on the left. It's not at the top of the table. So what we calculate from this example something called an odds ratio. Now I mentioned yesterday what an odds ratio is, and you all know how to interpret an odds ratio. Like you all know how to interpret relative risk and hazards ratio. The interpretation is the same. But what is an odds ratio? As the word suggests, it's a ratio. So it's something divided by something else. What we could work out here is the odds that the cases had the exposure. The odds of the exposure in the cases is A divided by C. The odds that the controls had the exposure was B divided by D, B over D. Now here you might ask, why it is I not saying A over A plus C? If we said A over A plus C, that would be a rate or a proportion or a percentage. So let's just say A was, just making up a number, A was 20 and C was 80. You could say 20% of your cases had the exposure in the past. Now that's not the same as saying 20% of the people with the exposure developed the disease. That is what we would say in a cohort study. What we say in here is 20% of the cases had the exposure in the past, right? So don't mix it up. So we don't work out rates for case control studies because rates could be misleading. We work out rates for RCTs and for cohort studies because those rates make sense. Those rates are actually incidence, how much people get sick or get better over time. Whereas in a case control study, we're not following up a group of people. We're looking at people who already have the disease and looking back in time. So we could calculate a rate, but generally we don't calculate a rate, we calculate an odds. So in that example, the odds of the cases having the exposure, if A was 20 and C was 80, the odds of the cases having the exposure would be 20 divided by 40 or 0.25 or a quarter. Similarly, here controls, we say B over B plus D. If let's just say here B was 40 and D here was 60. So you could say 40% of the controls had the exposure, but we don't work out a rate, we work out the odds that the controls had the exposure is 40 divided by 60, 0.66, 0.67. So we work out an odds. So here we have the odds of exposure in the, and here we have the odds of exposure, A plus A over C in the cases, and here we have the odds of exposure in the disease. If we take this odds and divide it by this odds, then we get the odds ratio, right? So we get the odds ratio. So look at this example. Here, 100 people had lung cancer, 20 of them smoked in the past. The odds that a lung cancer patient smoked was 4. How we get 4? 80 divided by 20. Here we have people without lung cancer, match controls, 100 of them, 10 out of the 100 had smoking in the past. So here was the odds. The odds is 1 over 9 or 10 over 90 or 0.11. So here we have this odds here, the odds that the lung cancer people smoked. And here we have this odds here, the odds that the control people smoked. If we take this odds and divide it by this odds, then we get the odds ratio. In this case, we get the odds ratio of 36. So what does this mean? To say it out in words, it means that the odds that a lung cancer patient smoked is 36 times the odds a control person smoked. 4 is 36 times 0.11. Is this odds ratio 1? No, it's a big number, it's more than 1, so that means there's a positive association between lung cancer and smoking. You could a positive association, because here you're seeing the odds that the lung cancer people smoked is much more than the odds that the control smoke. It's 36 times more. So again, if we got an odds ratio of 1, it would have meant that this number here and this number here was the same. And if both these numbers were the same, it would have meant that there was no association between the disease and the risk factor, right? And that's how we calculate these measures for a case control study. But before you kind of say, well, does that mean smoking causes lung cancer? It doesn't mean smoking causes lung cancer. What it means is there's a strong association between smoking and lung cancer. And as you can see from this list, that's just one out of the many criteria we use to say that a particular factor causes disease. There are 9 or 8 other criteria that should be addressed before you could say a particular factor is causing a particular disease. An odds ratio, a relative risk, a hazard ratio, all these measures only tell us about strength. I should put here strength of association. That's really what these factors tell us. But you not only need strength of association to say causation, you also need all these other factors to say causation. I'm not going to go through these. These are what we know as Hill's criteria for causation. Just to touch on one, temporal relationship means the person had to have the risk factor first, then develop the disease after time afterwards. So a person had to smoke for some years, then get the cancer after. A person couldn't have the cancer first and then smoke after, and then you want to say smoking causes cancer. Doesn't make sense. Dose response relationship means the more of the exposure the person have, the more disease we see. So if a person have 30 pack years smoking and we see 10% of them getting lung cancer, if we see a person now with 60 pack years smoking, we would expect probably twice as much people or more people to get lung cancer, much more than 10%. So it's a dose response relationship. Consistency means essentially many other studies have shown the same findings. Plausibility means it makes biologic sense. It makes sense that smoking causes cancer at the cellular or physiologic or pathology level. What it is about the smoking causing the cancer to occur. Smoking have carcinogens. Carcinogens mess with genes, produces changes in cells at the DNA level, and that mutation leads to cancer. That's the plausibility. I'm not going to go through the rest, but just to say, usually if you want to prove causation, you have to go beyond simply just reporting an odds ratio. You have to try to address all these other factors. What I'll do now, if there are no questions about case control studies, I'll look at and conclude with this thing called validity, right? So what is validity? You all actually raised this before when someone asked if the results of a study was trustworthy. And I said I like that word because if we asking if a result or a study is trustworthy, we're really asking if it's believable or true. So the other word for validity is truthfulness, trustworthiness, or if it's believable. So if I give you a study and I ask you, is this study valid? I'm really asking you, do you believe the findings of this study? And there are 3 factors that we use in determining if a study is really believable or true or valid. And the 3 threats to validity is chance, bias, and confounding. So we just have to understand basically what those 3 things mean, because any of these 3 things could actually reduce the trustworthiness of any bit of medical research done. Any research done, it could be a systematic review, it could be a RCT, a cohort, a case control. All these study designs we spoke about could actually have any of these threats to validity in them. The first one is chance. Chance means you do a study and out of pure chance, the study show a positive finding. So someone did a small study with, I don't know, some treatment for COVID-19. They did a study on 30 patients, 15 patients got the treatment, the other 15 got the comparison, and they said the treatment worked like magic. The people who got this treatment actually did much better. They were more likely to survive COVID in the hospital. They actually went home and they're living now. Again, it could be that that study produced findings out of pure chance. Suppose I told you the p-value for that study was 0.02. You would say, well, yeah, that is statistically significant, but that actually means there was a 2 in 100 possibility that that benefit the study found was due to chance. Now we say by convention we willing to accept it. Yes, it's less than 0.05, but there is still always a possibility, even when you interpret a p-value or interpret a 95% confidence interval, there is always that 5% possibility that you could still be wrong. The best fix, though, for chance is to repeat these studies. Repeat these studies, different parts all over the world, and do studies with more people in them. If you do that, you should see the true effect. If you repeat the study 10 times and 10 times it's saying, yeah, this study actually showed this treatment working, you're kind of thinking, yeah, this treatment really working. If you repeat the study 10 times, though, and the 9 times after you did it showed it had no effect, no benefit, then it makes you think, well, that first study was the outlier. That first study was probably something about that study probably produced findings out of pure chance. So the best fix to reduce chance threatening validity to our study is to do studies with big numbers of people and to do more studies over time. That's the fix for chance. There's bias. Bias is a problem with how the study is designed. Bias is a methodologic flaw. We liken it to inborn metabolism because it's like having an abnormal gene. If you have an abnormal gene, you're going to get the disease. In the same way, if you have an abnormal methodology or a study is designed poorly, it's going to always give you flawed results, right? So the only fix for bias is really to redesign the study. Yesterday, we saw some threats to bias in RCTs. One of the threats to bias we saw in an RCT was co-interventions. I'm just using it as an example. So if you design an RCT and you know there's a high possibility there would be co-interventions, you have to redesign the study and make it in such a way so that co-interventions will come into play to make the treatment look better than the placebo. So the only fix for bias really is to change the systematic way the study was done, to change the way the study was designed. The only way to fix a bias study is to redesign the study. There's no way you could fix a bias study after it has been analyzed and written up and published. If it's biased and it's already published, there's nothing you could do in the analysis that would fix it. The study was simply flawed from the beginning. And the last threat to validity is confounding. And I alluded to this when I gave the example of smokers versus non-smokers getting disease. How are we so sure is the smoking making people sick and not something else? For a confounder to be a confounder, that factor must be linked to the outcome of interest, and it must also be associated with other factors or be unevenly distributed between the groups. And this is really a silly example, but a good example of confounding would be to say something like people who walk around with a box of matches are more likely to develop lung cancer compared to people who don't walk around with a box of matches. So we could do a study like that, look at lung cancer people, a case control study, and ask the lung cancer people, you used to walk around with a box of matches, then ask controls, you used to walk around with a box of matches or lighters, and we could work out an odds ratio for the association between lung cancer and that risk factor of walking around with a box of matches. And we probably would find that the odds ratio is significant. Who knows? We might find probably a 5-time odds of association between walking around with a box of match and lung cancer. But of course, you all know the box match is not what causing the lung cancer. The box match is what being used to light the cigarette, which is what causing the lung cancer. So here in this example on this slide, the cigarettes is the confounder. So can cigarettes lead to lung cancer? Yes. Can cigarettes lead to lung cancer in someone who does not have a boxer match? Yes. Having a boxer match, is that associated with smoking? Yes. So those are the 3 criteria we use to say that a confounder is a confounder. The confounder must be able to cause the disease. It must be associated. The confounder must be associated with the agent you're looking at, but the confounder must be able to cause the disease even if this agent is not present. A boxer match could cause cancer, even smoking, could cause cancer, even if a person doesn't have a boxer match on them. Here's another example. Smoking or alcohol and esophageal cancer. Research has been done in this field to see if people who drink alcohol are more likely to get esophageal CA. And the research has shown that alcohol increases the risk of several cancers in the human body, not only esophageal cancer, but actually several cancers, especially if a person drinks excessively frequently or drinks a lot. Prof. Maraj will talk to you all more about alcohol and the effects on the body, but this hypothetical study is looking for the link, alcohol and cancer. Could there be a confounder? Could there be some other factor that would go with alcohol that could also cause cancer even if a person does not drink? Here, smoking is shown as an example. Smoking is the classic example here because smoking goes with alcohol. So a person who drinks alcohol is more likely to smoke compared to a person who does not drink alcohol. But smoking could cause esophageal cancer even if someone does not drink. So smoking meets the three-part criteria to be a confounder. Can anyone think of any other confounders here apart from smoking? Any other factor that could confound the association between alcohol and esophageal cancer? Usually students in class get this. Is there anything else that would go with drinking that could also cause esophageal cancer that is more common in people who drink, but could also cause cancer even if someone does not drink? Any ideas? One of the factors that usually most people come up with is GERD, gastroesophageal reflux disease, most correct analysis, not eating on time, which put you at risk for GERD. Can GERD cause esophageal cancer? Yes, you all know about Barrett's esophagus. Is GERD associated with alcohol use? Yes, alcohol actually causes reflux. Can GERD cause cancer even if someone does not drink? Yes, GERD could cause cancer even if someone does not drink. So again, GERD would be a confounder. And again, there are many confounders you could probably think about. So what we could do about this, can confounding be avoided? If we know what the confounders are, we could measure them and we could adjust for them in the analysis. Yesterday I mentioned the statistical technique regression. The great thing about regression is regression allows you to adjust for confounders. So sometimes they would see an adjusted relative risk or an adjusted hazard ratio or an adjusted odds ratio. What I mean is they're adjusting for the confounders. If we don't know what the confounders are though, suppose there are many factors that cause disease that we have yet to even identify. If there are confounders that we don't even know exist, then we can't measure them, we can't adjust for them. The only thing we could do for unknown confounders is to do studies like randomized control trials. Of course, you can't randomize a person to drink and randomize a person not to drink to see if they'll get esophageal CA, but at least for treatment, you could do randomization. And that's why randomization is so high up in the hierarchy of evidence. What does this mean? It means bias leads to associations that are false, but confounding leads to associations that could be true, but you could misinterpret it in a misleading way. And this is a common one we always see mentioned in literature when articles. People say there's an associated link between this factor and this disease, but it doesn't mean that that factor is causing the disease. The big point I want you all to get from this is association is not causation. Odds ratios, hazards ratios, relative risk, these could only measure association. By themselves, even if they're statistically significant, they do not prove causation. Remember, for causation, apart from the association, you also have to look at the Hills criteria, right? Which is this. And that in itself concludes the marathon of EBM. So I know it was long, I know it was a lot. I would pause now just to check in with you all to see if you all have any questions. If you all have any questions, you could post them in the chat. As you would see, I posted the links to the forums. I assigned persons to forums last night. So check your forum, see when it's due. I believe they're due by Sunday. I only give you a short time to conclude your forums because what would ensue after is a little bit of discussion. And I also know the quiz is due next week, Sunday. So I wanted people to kind of like get into the forums as soon as possible. So people have a few things to look at in the forums before they do the EBM quiz. All right, so if any questions? I take the silence in the chat to mean no, or people who are people actually asleep, which is okay. But if that's the case, if no questions, thank you guys again, and I would see you all, I believe, next week Tuesday for class as we go into some of the communication topics for this module. Okay, all right. So thank you all, and goodbye. Have a great weekend.